Today's video is all about helping you make informed decisions about medications when it comes to recovery. You know, it's not often that you get to sit down and have an in-depth conversation with a doctor about these types of things, which is why we are so lucky to have psychiatrist Dr. David Moore here with us to talk to us in depth about what he thinks about psychiatric medications, especially in early recovery. He's going to talk to us about antidepressants and anti-anxiety medicines. He's even going to give us his thoughts on prescribing stimulants for people who have ADHD in early recovery. And he's even going to weigh in on the topic of medication-assisted treatment. And of course, he's going to talk to us about sleep meds because sleeping is always an issue in early recovery.
Well, I think mental health and addiction go hand in hand. So when someone's right at the start of recovery, it is very difficult to tease out. And you kind of go with the assumption that their depression, their anxiety is most likely influenced by the alcohol or whatever substance they might be using. So it really takes time getting to know the person and then seeing them over time, which can be weeks and months, to then decide if this is really an underlying clinical depression versus all substance induced. And how you do that is looking at symptoms that are there in early recovery and then seeing how those symptoms progress, worsen, improve as they get clean from whatever substance they're on.
Does that make any difference as far as how you go about treating it on your end?
So a lot of people have a lot of myths about the antidepressant medicines, I think thinking they're way more powerful than they really are. They are not personality changers, they are not addictive type medications. And so a lot of times I will err on the side of, okay, the person in front of me is very depressed, I don't know the root cause of it, but in order to help them in their early recovery, we may go ahead and start an antidepressant medicine. It's not going to hurt anything. It's not going to jeopardize the recovery. And then if it's really not needed later on, we'll get rid of it. It won't have harmed anything. But I think a lot of people may have myths about them, thinking that they're somehow doing something that they really aren't that powerful to do.
One of my clients, just reminds me when you said that, one of our clients that we have in our program now was saying, we were like going back and forth. I wouldn't call it arguing, it's more like fun discussion or whatever, but he was saying that he thinks if you take any medication, whether it's like antidepressant or ADD medicine or anything else, even if it's a non-addictive medicine, and you're dependent on it, he's like, I don't really see what the difference in that is in addiction. And so we were going around and around. Do you ever thought of that? Just because it's weird to remember.
Well, I actually think, and I've certainly been involved in people in the AA recovery community who also can take a very hard line that recovery means absolutely no substances of any kind. But we have to remember the brain is an organ of your body. And just like the heart can have different diseases associated with it, so can the brain. And so while addiction can be one disease associated with the brain, so can depression. And they don't necessarily, they're not always overlapped. And they can be separate entities. And if you just ignore whatever else someone needs to be treated for, one, you make them suffer through sadness or anxiety or panic or whatever they may have. But if they also have an addiction issue, you're really setting that person up for a rough road in recovery.
Do you think it raises their chance of relapse if you don't treat an underlying condition?
Absolutely. I mean, I'm sure everyone has heard the term where someone is self-medicating through whatever substance they are. And someone is already battling kind of the demons of addiction already, but now we've got to add in, well, you're going to have panic attacks too, but you can't do anything about it. I mean, that's painful. And I think at some point, people become very vulnerable to a relapse or whatever they used to use to self-medicate.
I call it getting to the efforts. Just getting to the point where you're just like, forget it.
Okay.
And you're just like, screw it. If this is what sobriety's like, I don't want it.
Right. That's
I think
painful.
That's a possibility.
Absolutely.
What about when it comes to, because we run into this a lot, do you feel the same way if it comes to something like ADD or ADHD and someone's in recovery? Would you medicate that? If you would you medicate it with a stimulant? Would you not? What's your thoughts on that?
Well, so let me tell you my thoughts on ADHD first, regardless of addiction or recovery.
I gave you a giant question on that.
Yeah. And that is, I always ask the person, if we're going to treat your ADHD, what exactly do you want to accomplish? And so if they're currently in school or job or whatever they're in, I want to know why they need that medication, what it's actually going to be doing for them. Because I've got some people where they're not in school or their job is not really something very tedious. And then my question for them is, well, why take this medication? And so ADHD then becomes, first, why do you need it, and do you really need a stimulant or not? And that's regardless of whether someone has an addiction history or not. But then if you add an addiction history on there, that becomes a very, very slippery slope. I am open to treating it with a stimulant, but maybe just like while they're in school, and then when they're out of school, we don't do it. Or maybe they're in a job where in the future years they can work into a position in career-wise where they don't need it anymore. Now, if they're an accountant, they're going to need it for their whole life. But outside of being an accountant, most careers can hopefully advance where you don't need attention deficit medication.
Well, are there any medications that you definitely steer away from when it comes to people in early recovery?
So one of the issues in early recovery is people are going to have sleeping problems.
Oh, yeah.
And so that is almost 100% sleep is an issue that you have to talk about with people in early recovery, because sleeping pills are not where you want to go in any stage of recovery. There are other ways to help sleep, some of them behavioral, some of them over the counter, and then some of them non-addictive prescription sleeping pills. But it kind of depends on the person and where they are, and a lot of them will start out like, no, I need heavy duty stuff, but most people don't. Once you start getting the addictive substance out of them, you can find other roles for sleep. So sleeping pills, I think, are really a slippery slope, and you have to try to avoid them. At the same time, people need to sleep as well, but there are other methods besides what people may think are the only options for sleeping pills.
Right. I'm glad you brought that up. That's huge. I don't know that we've ever treated anyone here for addiction that didn't have sleep problems early on. I mean, it's definitely part and parcel. And I used to have a friend who was in long-term recovery, and he used to say that his sponsor told him lack of sleep never killed anyone, which I kind of agree with. But I also know that the research says that rate of relapse is highly tied to sleep. So if you get 7 hours of sleep, your rate of relapse is like significantly less. So it's just like, well, I don't know, what do you do there?
Well, I don't think anyone's ever died with one night of bad sleep. But now if you start to have weeks of bad sleep and months of bad sleep, that's something else. It's going to start to affect not only concentration and mood, but it's going to start to affect blood pressure and blood sugar kind of readings related to chronic insomnia. So it is something to take seriously, but I agree. One night of bad sleep, you're going to have to tough it out. But chronically, that's painful, and something needs to be done about it.
Right, for sure. Now, can I ask you about things like medication-assisted treatment, which in my mind is a little something different than, I guess you could say, if someone's on an antidepressant and they're in recovery, you could call that medication-assisted treatment, but I'm really referring to like things like Suboxone, Vivitrol, some of those other things that are used specifically to treat the actual addiction.
Right.
And this is our time. You can say whatever you want.
Okay.
Whatever you don't have to be PC.
So I think that the reason Suboxone and Vivitrol and naltrexone and even things for anti-smoking like Chantix, why they exist are there is a benefit to them. But most of them, in fact, probably all of them are really meant to be time limited, and none of them are meant to just replace a substance and now you take it indefinitely. That's where methadone used to be slotted, and while that is still a slot that methadone performs, most people really don't want to be on daily methadone for years and years and years, and it's really not the standard of care anymore.
Okay.
The standard of care is using substances to help someone aid in early recovery to get their foundation behaviorally and mentally in early recovery so that they can eventually get off of things like Suboxone or Vivitrol, or even just take Chantix. If you want to quit smoking, you don't want to be on Chantix or an anti-smoking patch or gum indefinitely. You want those to go away eventually. It's the same thing is true with any kind of alcohol or opiate related issue too. And I think part of our field has gotten lazy in, oh, they're on Suboxone now, they can just stay on Suboxone forever. But that really isn't the intent of the medication. It was never intended to be the intent, and it still isn't the recommendations by the addiction psychiatry boards.
Right. Seems like there's a little bit of conflict in it, because I definitely sort of get the idea of doing it on an outpatient basis. And in fact, if I can avoid sending any of our clients to detox, I do, because who wants to do that? Right? If you don't have to. But while it's definitely theoretically doable to taper yourself off on those like Suboxone and that sort of thing, I'm not real sure how recovery doable it is, because it kind of is like you're saying, okay, you can't control your substance use, but I want you to control this Suboxone taper. So what do you think about that?
I do not think the healthcare industry have really gotten on how best to deal with especially opiate addiction. And opiate addiction is talked about in the news every day. It is becoming bigger and bigger. But I really do think somebody has got to step up and say, well, how do we do this in the best possible way? And I agree. Doing it as an outpatient and saying, oh, here's some Suboxone, now today take this much, and next week you're going to take this much, is just unrealistic. And it doesn't work without a lot more intensive treatment.
What I think I hear you saying is it can be done, but it needs a lot of structure and support to make sure it happens.
Oh,
back
absolutely.
it up, I guess.
Absolutely. Yeah, I think it's very hard. No matter, even if the person has the best intentions, it's tough. And if they don't have the best intentions and they're only kind of half in, half out, they have got to have people helping them through the process and supporting them and keeping them going. While opiate withdrawal feels bad, it is time limited, it will go away, and then you can really get on the road to recovery.
So as a psychiatrist, a busy psychiatrist in private practice, how do you work with a team? I know it can be a lot to sort of coordinate. Well,
so I think a part of healthcare, and this isn't just mental health, but all kinds of healthcare requires a team approach. And I think of something like if someone got a cancer diagnosis, of course they might need an oncologist, but they also might need a nutritionist too, because their weight's going down, or a therapist. There's a team that needs to be in play. Well, in mental health fields, eating disorders and substance abuse 100% needs a team approach. I myself, anytime I see anyone with those kind of conditions, if I'm the first one they're seeing, I know I can't do this on my own. In my current job, in which I'm in an office all by myself, is the fact that I can call or email anyone here at Hope for Families or other nutritionists or other centers, residential centers, and know that I'm not in this alone. They're not in it alone. And I also think the patient, the client feels, okay, there's a lot of people here who've got my back. And I think they can sense that. At least I hope they sense that. And I think that provides even more of a chance for really good outcomes.
That's one of the things that we love about you so much, is you are so easy to communicate with and willing and to be honest, most psychiatrists really aren't. And you're so good at that.
Well, I think, unfortunately, and this may get into more of my own personal beliefs, but since I don't have to be politically correct on this, if I was a psychiatrist that was taking insurance, I wouldn't have time to do all that. It just wouldn't be financially possible for me to and stay in business. Mm-hmm. And so in practicing the way that I do without taking insurance, and I realize there's criticism with that, it really enables me to spend the time I need to with everybody, regardless of what their condition is. And that's how I was trained. That's how I have trained residents when I've been in teaching roles. And it's just the way I think is best.
Absolutely.
I think everybody is capable of getting clean and sober. I don't care how much they've used. I don't care the negative consequences that have come from it, whether it's financial, health related. People can recover and get healthier. And I think there are, especially in families, where they think we've tried everything, there is nothing else we can do. Everybody is going to reach a point, hopefully everybody reaches a point before something super serious happens, where they've hit the bottom. And sometimes I think that bottom is, I've often thought with people, oh, well, they're at the bottom now, only to find a couple months later, there's even more of a bottom.
It gets lower.
It gets lower.
Yeah.
But at any point, I think people are able to start recovery, and I don't want to give up on somebody as long as they're also working toward recovery. One of the things I think we all know in this community is if we, meaning the therapist, the psychiatrist, the family members, if we are working harder at this recovery than the person is, mm-hmm. That's not going to work. Mm-hmm. That's not going to work. The person has got to get in and be working as hard as everybody else. And again, in the early recovery, that may not be the case, but as you go forward, that's really got to be, that's where people get sober and stay sober and have years and years and years of rebuilding their life in a really great and positive way.
So if you're still alive, you're still in the game.
If you're still, that's great. I have not used that before, but I agree with you. If you're still alive, if your heart's still beating, you can still get clean and sober.
That's right.